Hello, everybody. I'm Dr. Andrew Leitner. I'm an anesthesiologist and interventional pain specialist, and it is such an honor to talk to your group today about this important topic on cancer pain, and not just share with you, but also learn from you. You see patients with incredible scope of pathology, and we have a lot to learn from each other, so it's really an honor to speak with you today. This is going to be a brief whirlwind presentation, so I'm going to go through these slides fairly quickly, but we will have some time for questions afterwards. And I wanted to give a scope of context for how cancer pain treatment in the US came to be and some of our approaches to management of these patients. I don't have any disclosures. I did want to start just giving an overview of what we'll talk about today. First, going through the history, and this is really a US history, because to understand the current context, we do need to go through some of what led to the current treatment paradigm. We'll go through types of cancer pain, our approach to the treatment of cancer pain, which really comes through treatment modalities as opposed to just one modality, and then spend a couple minutes talking about survivorship. In terms of the history of cancer pain, we'll look at where even some of the word origins came from, the history of opium, but ultimately the 1800s was a pivotal time in formulating how pain management came to be in the US and even globally. And then we'll describe the modern era of cancer pain. So if you look at the English word for pain, the derivation is from the Greek poina. She was the goddess of retribution and vengeance. The Latin word poena similarly meant punishment, and tells you a little bit about even some of our current cultural approaches to the experience of pain. A history of pain would not be complete without looking at this plant, this key plant, Papaver somniferum. This is the sleep-inducing poppy is the definition. And opium has been used for thousands of years in different cultures for a variety of ailments and conditions. It was in the 1800s, though, that morphine was isolated from opium, and then it was finally manufactured in 1827 by the Merck Company. Subsequently, other medications were developed as well, including heroin, which was in commercial use for some time. There were other medical advances that made access to opioids in different formats, including the hypodermic syringe. And this is a picture of one of the earliest in England. Just to give a sense of how widespread opioid use was by that point, middle of the 1800s and late 1800s, this was an advertisement for families with teething children that were crying and uncomfortable. This is Mrs. Winslow's soothing syrup, which contained two active ingredients, alcohol and morphine. So opioids were everywhere. Clearly, there were problems with this. And as the problems began to mount, there became a regulatory backlash. And so by 1914 in the US, there was a narcotic act that essentially restricted the legal use of opioids in clinical practice. And it just fell out of favor. It was almost unheard of to use medically used opioids. And at that time, there was this pervasive idea that pain was a spiritual or an existential test of character, back to even some of its word origins. So at that point, we're leading to the early 20th century, morphine was felt, it's just a last resort. It was often not used at all. And if it was used in the last days of life. And these were for patients, especially with cancer, they presented with advanced disease almost always. Hospital facilities were rarely used for these patients. They were either at home or in a domiciliary setting, and it was difficult to administer those drugs there. Fast forward to the key time of pain research and looking at pain management as a field in the US came in about the 1950s, 1960s. And at that time, the idea was, let's look at pain from a mechanistic standpoint. What are the pathways of pain, and can we interrupt them? Can we interrupt them surgically? Can we interrupt them chemically by nerve blocks or different neurolysis procedures? But even at this time, the consensus was we should do these and pursue all available mechanisms because opioids are a last resort. This is a common sentiment at the time. If you look at the last sentence, if surgery is withheld in order to treat the pain, the sufferer is doomed to opiate addiction, physical deterioration, or even suicide. So it was felt that this is a binary thing. Either patient has a surgical or a interventional approach to pain, or they are doomed to opioid addiction and physical deterioration. Fortunately, in the modern era, we know that there's a wide range of alternatives. The modern era is really looking more at the patient. What is the patient experiencing? Pain is clearly still, it is a subjective experience, even if it is based on various pathways. But that promotion of the idea that pain is what the individual feels and thinks it is. And out of this sentiment comes really the modern hospice and palliative care movement and meeting patients where they are. From a research standpoint, there were things that coincided with cancer pain, and this was in the mid-'80s. And by 1986, World Health Organization first published their cancer pain stepladder. And today, this stepladder can be seen in textbooks throughout the world, in presentations, and it's still somewhat of a bedrock of how we approach cancer pain. What's interesting, particularly in the US, is what was specifically a cancer pain stepladder has now been often applied and even misapplied to non-cancer pain states, degenerative states, chronic pain, where there can be issues with that, which we will discuss. But the principle of the stepladder is, incrementally increasing both number and dosage of various analgesics for patients suffering from cancer pain. So, in non-malignant pain, as I referred to, prior to the 1980s, opioids were reserved for last resort. At around the same time that the stepladder was published, there was a Sentinel article by a group in the US asserting that opioid addiction was not an issue for patients on chronic opioid therapy. Less than 1% became addicted. Opioids are easy to discontinue. Overdoses are extremely rare. And out of that article and subsequent studies and anecdotal experience, there became widespread use of opioids in medical use in the US. But if you look at the bottom, this was a report of 38 cases. So the evidence to support this was actually pretty flimsy. And as you all know, the US is continued to be in the grips of a opioid epidemic. This is a 10-year chart, and it's already now pretty dated, but it pretty clearly shows that as the supply of opioids on the market increased, the number of treatment admissions for opioid use disorder or overdose, and also deaths, which is the red line, they went in hand. And a few years ago, really 2015, 2016, the US identified this as an epidemic crisis and with a significant regulatory response to it. The challenge has been that these patients or users of opioids, it's not a consistent group. There's areas of overlap, but in fact, there are multiple distinct groups. And those who are experiencing overdose and overdose deaths are in many cases, if not the majority of cases, not patients who are having pain or chronic pain. Also, the way in which folks are dying is the potency, particularly fentanyl within some street drugs and heroin today, and not a prescription opioid driven death rate, particularly in the last few years. But it's a moving target, and it's a tremendous challenge because we know that pain, the treatment of pain, and addiction can overlap. And what do we do to mitigate this? I did look through because I wanted to understand a bit of some of the unique differences in resources and barriers to opioid therapy within Kampala and some of the African cancer centers. And so some of you on this meeting may have been involved in this work or are familiar with it. So this was an education to me. But similar to in the US, prevalence of pain in cancer patients, moderate to severe, is high. And one of the challenges has been access to opioids. And the access is not just in supply, but in number of prescribers per patients that can write for it. So I understand that in Uganda and several other countries, there is some legislative allowance for non-physicians to prescribe morphine as a way of improving access. So I would be curious to learn more about that and how that has worked. This came from a Palliative Care Association meeting a few years prior, which was in 2007, pretty much putting into categories what are the barriers. Are there policy issues, clinical issues, and resources? And it was just educational to me because some of our access challenges in the US are mostly regulatory. Sometimes we have supply issues, but it's mostly on the regulatory side. But understanding other clinical issues and policy issues is very helpful and obviously critical when you're in that practice setting. Let's get back to what is the overlap in cancer patients and the risk of opioid overdose. So generally speaking, the rate of overdose is lower in cancer patients. There are subgroup exceptions, and clearly those with renal and liver impairment will have higher risk. And then cancer patients were not cancer patients before they had the diagnosis, and they're subject to the same risk factors. If they had previously had substance abuse, polypharmacy, and then the higher the dose, the higher the overdose risk, whether it's a cancer patient or not. There also is a subset, if the rapid up-titration of opioids occur, then sometimes you don't have the benefit of tolerance, which is protective for overdose. But if they're escalated quickly, you don't have that as much. Let's talk about what are the things that cause cancer pain. There are nociceptors that can mediate somatic pain. These are musculoskeletal, fascial planes, often from the metastatic or local extension of tumors. There's pain from the viscera, which typically has a different quality and referral pattern than many of the somatic pains. And then, of course, neuropathic pain with its own set of qualities that are listed here. The reality is, with most, especially solid tumor pain states, you have combinations of all three of these, and just isolating and saying this is only one or the other may not be as helpful. But certainly taking a pain history and understanding the quality of the pain can help make some treatment decisions about the most effective analgesics. The majority of pain in cancer patients is related to tumor involvement. Roughly 25% of the pain, however, is associated with cancer therapy. And then if you look at survivors, that number shoots way up. Then there's pain that's unrelated to cancer therapy. So if patients had chronic pain states before their diagnosis, often the pain gets worse for a number of reasons, which we can get into. And then, of course, there's a somewhat separate category of generalized pain. This tends to be less well localized in a dying cancer patient. Within the direct cause from cancer, the bone pain syndromes are the most common, but the other ones listed here are also highly prevalent depending on the types of disease you see in your center. As far as syndromes associated with cancer therapy, post-chemotherapy pain syndromes, at least in our experience, those are the most common, particularly the chemotherapy-induced neuropathy. We also have a number of survivors that have pain with hormonal therapy. These tend to be in the musculoskeletal pain category. We see a lot of post-operative pain syndromes, and depending on the innervation of the various surgical approaches would tell the type of pain syndrome. And then, of course, we see a fair amount of post-radiation pain syndromes. I would say for each of these, as therapy has advanced, the prevalence of pain has gone down, but those that have it, the severity may be just as high. So an example is as mastectomy has changed from all women having radical mastectomy to more focalized surgery, sentinel lymph node, et cetera, the prevalence of post-mastectomy pain has gone down. It is still pretty high, and those that have severe symptoms, they're as severe as they were before. Related to tumor involvement, as we mentioned, bone pain is the most common cause. It may be primary or metastatic. The vertebra are the most common site of bony metastases. We see a number of patients with epidural extension of disease and or spinal cord compression, and we involve our neurosurgeons with those cases. Visceral pain is the second most common, and I've listed here some of the causes of visceral pain, which I think we all see in practice. Then, of course, there's the peripheral nervous system, plexopathies, radiculopathies, and mononeuropathy. And my clinic tends to see more of these because of some of our interventional approaches to them. Then, of course, there's mucositis, post-procedural pain, as we talked about. And in our center, we do a number of stem cell transplants. And so we have a fairly significant burden of graft versus host disease. What is our approach to treating these various pain states? The main principle here is about modalities. The idea with a multimodal approach is you can spare some of the side effects and or complications of monotherapy, just focusing on, let's say, a pill at high doses by approaching pain from different modalities. This also gets to some of the mechanisms of pain, which is not purely a physical experience, but it has a number of psychological overlays, depends a lot on behaviors and physical functioning. So we'll go through all of those. But anytime we see a patient that is suffering from pain, we think in modalities and how to approach it from as many angles as possible. So this gives a visual of some of those perspectives. So I am on this bottom part. You can see medical, pharmacological, interventional, but I recognize that this is part of an overall treatment paradigm. And we kind of go around in this circle and try to consider all of them for treatment of patients in pain. Now, I have psychological up top. I'm not covering that today, not because it's not important, but we just don't have time and it's out of scope. But I will try and get into some of the others. As far as physical medicine modalities, integrative approaches, pharmacologic approaches, some of the things we do for hospitalized patients, and some of our interventional treatment modalities. For the physical modalities, we work pretty closely with our physical therapists and occupational therapists, as well as giving patients specific things to do at home. The idea here is about desensitization, habit forming, exercise, ways of rehabbing patients after treatment or during treatment, and in some cases before treatment, which is called prehab. So exercise itself has been shown to have pain benefits. Postural re-education, particularly after surgery, various types of massage. Then there is modality specifically for pain areas like TENS, transcutaneous electric nerve stimulation, which are patches connected to electrodes, and then various forms of heat and cold therapy. I'm not covering integrative approaches because it's very location dependent. So the type of modalities used in the US, I believe, are quite different from what you may see in Europe, Asia, Africa. But we all know of the things that our patients are doing to try and get pain relief. And so it's important for us to understand as clinicians, what role that plays in their pain care. And just a quick note, the placebo effect is a real thing for patients with pain, and perceiving that one is taking proactive steps to relieve pain is very empowering for patients and should be encouraged, even as we're trying to build the evidence for some of these things. On the flip side, we do have to understand if certain particularly supplements may be causing harm, and we have to educate our patients accordingly. So for the pharmacologic approaches, we certainly are still referring to the step ladder. We start with non-opioids and adjuvants for mild and or manageable pain, thinking also about a number of the other modalities for these patients too. One of the principles I want to mention is we don't wait to get to step 3 before we consider non-pharmacologic approaches. Non-pharmacologic approaches should be considered at all steps of the step ladder, and we do. But as far as opioids are concerned, we think about pain states that are more continuous with significant pain flares, breakthrough pain. And at that point, we're looking at dose increase, medication rotation, but using opioids as well as non-opioids. For some of the non-opioids, over-the-counter medications are highly encouraged for most patients, Tylenol, Advil. Clearly, you have to be concerned with patients with bleeding risk, gastritis, liver toxicity, but those that don't, we actively encourage these. There's a number of topical formulations which we can get into, use of steroids, and then of course the nerve pain states often are better addressed with neuropathic pain medications, various antidepressants, and there are approaches to muscle relaxants as well. For some of the more acute pain or progressive disease, we think about, are patients getting the right benefit and without intolerable side effects? And often changing the route of administration is necessary, whether it's IV, transdermal, intrathecal, which we will get to. The goal here is really reduce the pain and also reduce symptoms maybe caused by cancer treatment and or pain medication. Bowel function is a critical one, particularly with patients on opioids. And we focus on gaps in analgesia. So for some of these, for our hospitalized patients, using epidurals, using perineural infusions are sometimes utilized, and of course, non-opioid adjuvants and IV infusions. For many of our surgeries, particularly thoracic surgery, we do employ epidurals for a few days after surgery, but they can be used after abdominal, orthopedic, gynecologic surgeries as well. And this, presents many potential benefits, blunting the stress response, increasing return to bowel function after the surgery, some pulmonary function improvement, and facilitating ambulation. The same degree of pain control from systemic opioids may cause more side effects that would delay things like rehabilitation and discharge. This just shows a picture of a pump we often use that's filled with a local anesthetic, bupivacaine, commonly ropivacaine, that can be placed perineural catheter the patient has for a few days or a week. And there are different delivery systems, but patients can also be sent home with these as they recover from surgery.
Right, we're about 22 minutes in.
Okay, thank you. Ketamine, I did want to speak about, has been around since 1965. It is a wonderful medication for the right patients, and it can help with both opioid sparing, potentiate the impact of opioids. It is a dissociative, so there is a ceiling effect. I tend to have patients on an infusion of roughly 10 milligrams an hour, but one of the advantages is it reduces pain perception and pain behaviors, and it is not associated with the respiratory depression that you do see with uptitration of opioids. It also does not cause hypotension. Really, the only patients I avoid it with are those with tachyarrhythmias, with increased intracranial pressure, and those that have previously had a untoward experience with ketamine, significant hallucination, et cetera. But at these doses, we tend not to see it, and benzodiazepines can help. I do want to spend the last few minutes talking about some of the interventional techniques. So why do we do them? We do them if analgesia is ineffective with medication or other modalities alone, or if side effects are intolerable. And early interventions have shown better outcomes. I will refer to a study on this. But they should be considered in the dying patient as well, not just early on, or if patients have had significant opioid side effects. So we use spinal cord anatomy in order to determine where our interventions are performed based on dermatomes largely. Trigger point injections, very helpful for myofascial pain. We do ultrasound-guided injections for perineural as well as fascial plane blocks for some of the chronic abdominal pain, post-mastectomy pains. We do X-ray guided injections as well. A lot of this is for neuroaxial pain, degenerative or cancer mediated. This just shows you some of the viscera we can target, particularly with sympathetic nerve blocks. We can do neurolysis, for instance, pancreatic cancer patients, neurolysis of the celiac plexus. This gives an example of one on the left, that's a celiac plexus block. Radiofrequency techniques can be used to burn some of the sensory nerves, particularly in the medial branches for the spine. And then intrathecal pumps, for those that are refractory systemic opioids, done with the right patient selection and early in the course of the disease, can actually affect survival. And I want to show you one slide that shows a Kaplan-Meier survival curve. The blue is are patients with intrathecal pumps. The red are patients on conventional medication management. So this basically demonstrates that good pain control for certain cancer states can actually offer a survival benefit. We consider it for those patients for whom they have intolerable side effects or those with uncontrolled pain with medical management. What I will do is I'm going to pause here because I think it's a good time for us to take some questions. And also survivorship, I think, is very regional dependent depending on the types of cancer you see, but we can get into that a little bit later. So thank you so much. Such an honor to present to you, and look forward to your questions.
Hi, this is Dr. Ken Miller. And first I want to thank Dr. Andy Leitner. That was a wonderful talk, and you covered a lot of material. So thank you. I do have some questions that we got during your talk, and I'm gonna paraphrase them because some of them are long. This was from a colleague in Zambia, sort of commenting that it was the 1980s when the WHO stepladder was developed. We still see it in the textbooks. If you were to rewrite or redo a stepladder now, would it be any different?
That's an excellent question. I would redo a stepladder, and unfortunately, one of the elegant benefits of the stepladder is it's fairly simple, and I don't think we can make a stepladder simple for the cases of patients. So if I were to add to the stepladder, I would also put the other modalities there, and not in a stepladder fashion. I would take two core principles. One is patient-specific factors and also disease-specific factors. And so there's this big trend in the US right now about shared decision-making. And so one type of treatment for a specific patient may not be in line with the values, goals, and preferences of another patient. And so I'll give an example. I have some patients that are incredibly needle phobic. They don't want to have surgery under any circumstance. They're petrified. The anxiety of the experience, it outweighs any potential benefit they would have. And so those patients, the interventional modalities are not really on the table. And so we focus on others. There may be other patients that have a history of substance abuse and they are acutely aware of what the risk factors are for exposure. So for those patients, we tend to focus on non-pharmacologic modalities or non-opioid modalities, physical modalities, frequent monitoring when we do start opioids. And so a tailored approach ends up becoming more important. That being said, I do want to recognize that after decades of use of the stepladder, it has still been validated as an effective approach for the majority of patients. So we are talking about there is a subgroup of patients for whom that's not the case, and I think we need a custom tailored approach for those.
Yeah, thank you. It's very interesting to hear your perspective. We have two questions that may dovetail on each other. One is from a colleague in Sudan and one from Ethiopia. For patients, and I think you did discuss some of this, but for patients who have cancer pain and are treated with appropriate doses and careful follow-up, let me phrase their question. Is there an addiction risk, and how great is that risk? If a patient were to say, doctor, what % risk am I of developing an addiction? What would you say?
So part of it depends on how addiction is defined. But I would say that some degree of adverse effects from using more than is prescribed or wanting to use more than is prescribed and running into sentinel events, for instance, near overdose or hypoxemia or apnea, that's typically less than 10% of patients. But understanding what 10% that is can be a challenge and is usually based on history. I will say that to the extent that cancer does affect patients, later in life, that someone who has not had an addiction or substance use disorder by the time they're 40, 50, 60, they are unlikely to develop it just because we've started them on opioids. This is part of the reason why we tend to see more issues with substance use disorder, primarily with opioids and cancer pain in younger patients. There's a few reasons in terms of prevalence, but what I would also say is close monitoring tends to minimize the risk significantly. So even patients that are genetically, there's a large genetic determinant predisposed to addiction, you can pick this up pretty early and carefully guide patients in dose ceilings, follow-up, use of adjuvants. And so I have tapered patients who've had substance use disorder. I've restarted opioid therapy on those who are going through treatment. And with close monitoring, you can reduce most of the risk associated. We don't want cancer patients that have previously had substance use disorder to just not have access to opioids, but it just has to be watched, and careful scrutiny of dose amounts, usage, and pill counting, things like that.
We had an email from Kenya, basically asking, can you say more about self-management of pain?
So self-management is such a great question, because another cultural aspect of, I think, pain in the US has been, as the reliance on the individual, the family, and the community has probably gone down. Now there's more reliance on the medical system to help with particularly some of the emotional burden of symptoms and of pain. And so this is a good chunk of the opioid epidemic, is there's a pill for everything. And so self-management is one of the most powerful things that we have, but many people will need some training on it from either a coach or a family member that has some experience. It's not the type of intuitive thing. The other challenge is cancer patients, when they have pain, there's a huge fear component. The disease is progressing, the disease has recurred. And so managing the anxiety of that can be a challenge. Typically, self-management comes down to breathing techniques, attention to daily physical activity, as well as a lot of pain is mechanical in nature. There are certain things that you can do or stop doing that help with the pain state. And so starting to learn those. So patients that have spine, I see a lot of patients with spine-mediated pain. There are certain stretches, there are certain daily habits in the morning, heat and stretching, taking certain medications prophylactically. That's all part of self-management, and the routine, I think, is really important.
And finally, I have one last question from Tanzania. A lot of they're writing here that a lot of their patients are receiving hospice and palliative care at home. What do you recommend for patients with truly refractory pain at home, where it's and where hospitalization is not going to be practical or desired?
Right. There tends to be two groups of refractory pain patients from my experience. There's the group for whom they still will be able to achieve pain control, but they have to have dose elevation and probably use of multimodal pharmacologic medication. So let's say in addition to morphine, they may also need to be on steroid, NSAID, muscle relaxant, anti-anxiety medication, et cetera. But in combination, they can achieve pain control. If the oral route isn't possible, a similar principle, through IV. There is, unfortunately, another group, and it's a smaller group, that despite that, they have refractory pain, and that tends to be really end of life. And in that group, there are a couple things to consider. This is why I mentioned ketamine. Ketamine has had a significant role in palliating patients who are otherwise refractory. And I don't know what the supply chain looks like in some of the African nations, but I will say in the States, it's a cheap drug. It's been in production since the 60s. So, I'd highly encourage consideration of that. It can be formulated in a solution orally as well, in addition to IV. Then there's palliative sedation, but that can be very tricky to do in let's say in a rural hospice home-based fashion. So, I think I would still start with pill medication management, but considering some other agents, and ketamine would be high up on my list.
Very good. I want to thank you, Dr. Andrew Leitner from City of Hope Cancer Center. That was a great review. So thank you again.
Thank you so much for having me.